Welcome back to the deep dive. We're here again to take some pretty complex medical topics and, well, make them make sense.
That's the goal.
Today, we're diving into something that often causes, immediate panic. Breast symptoms.
Yeah, it's a sensitive area, literally and figuratively.
Exactly. We're looking at infectious and inflammatory disorders of the breast. We want to explore why things like a lump or discharge or sudden pain, while definitely scary,
Understandably so.
are actually often a sign of something inflammatory or, benign, rather than the first thing everyone fears, which is malignancy.
Right. And if you or maybe someone you know has experienced sudden breast changes, that fear is this cancer. It's almost automatic.
It dominates the conversation.
True.
And look, for good reason, breast cancer awareness is vital. But the source material we're looking at makes a really critical point right up front, that most patients who show up at a specialist office with new symptoms, they're actually dealing with these really common non-cancerous conditions, inflammatory, infectious. It's a whole range of things that maybe don't get as much airtime.
That's such an important perspective. For the patient, absolutely, but also for clinicians starting that diagnostic process.
So when we talk about infectious and inflammatory disorders of the breast, what exactly are we including under that umbrella?
We're looking at a specific and very common group of non-cancer conditions. Think acute or chronic swelling, pain, redness, sometimes even tissue breaking down a bit.
Okay.
It's a regular presentation in breast clinics, a high-volume thing, and it tends to pop up more often in certain situations in a woman's life.
Right, and I think culturally, many people immediately link breast infections to, well, one specific time, the postpartum period, right? Breastfeeding.
That's definitely a big one, yeah. That connection is correct, but it's not the whole story. The postpartum time, especially those first few weeks of breastfeeding, that is proportionally the most common time for acute infections, what we call puerperal mastitis.
Got it. Puerperal mastitis.
But, and this is key, non-lactational infections, so infections happening outside of breastfeeding and also chronic inflammatory conditions, they're also pretty frequent. And frankly, they can be trickier to diagnose because you don't have that obvious link to lactation.
Okay, so understanding that whole scope, that's our job today. We need to sort of categorize these issues, figure out the treatments, especially where things have really improved, become less invasive.
Exactly.
Our sources seem to break it down into four main types. You've got acute bacterial infections.
Yep, the classic infections.
Then chronic inflammation linked to the ducts, like periductal mastitis.
Correct. More of an internal plumbing issue almost.
Okay. Then glandular problems like hidradenitis.
Which is more skin-related but can affect the breast area.
And finally, this really interesting one, Mondor's disease, a vascular thing.
Yeah, a benign vein issue. Sounds dramatic, but usually isn't serious.
Before we get into those four, you mentioned a fundamental split for the non-lactational problems.
Yeah.
How clinicians first think about it.
Right. For non-lactational issues, the first big question is this intrinsic or extrinsic?
Intrinsic versus extrinsic. Okay, tell us more. Why does that starting point matter so much?
Because it points you towards very different causes and therefore different treatments. Intrinsic means the problem starts inside the breast itself.
Okay, within the breast tissue or ducts.
Exactly. An internal abnormality is the root cause. Think periductal mastitis. The inflammation begins within the walls of the milk ducts. It's an internal structural issue.
Right.
Extrinsic, on the other hand, means the problem started outside the main breast tissue, usually in an adjacent structure, like the skin or a gland nearby.
Like an infected cyst.
Perfect example. An infected sebaceous cyst starts in the skin, but might grow and affect the breast tissue underneath. The key difference is intrinsic problems, like periductal mastitis, might need surgery on the ducts themselves because it's a deeper recurring issue. Extrinsic problems, like that cyst, are often just skin infections. Antibiotics, maybe draining it locally, and it usually resolves completely, much simpler.
That distinction makes a lot of sense for guiding treatment.
Yeah.
Okay, let's dive into the details then. Section A, bacterial infections and abscess formation. When an infection does take hold, who are the usual microbial culprits?
Well, the literature is pretty consistent here. The bugs we most often find in infected breast tissue or, say, nipple discharge are Staphylococcus aureus staph,
The classic one.
and Streptococcus species strep. But here's where it gets interesting clinically.
How so?
They often present differently in the breast. Their pattern of attack, if you like, can give you clues even before the lab results are back.
Okay, so if someone comes in, red-hot, painful breast, how might staph look different from strep initially?
Staph infections really like to localize. They tend to form a distinct abscess, a walled-off pocket of pus.
Right, a collection.
Yeah. So you're looking for point tenderness, a very specific spot that hurts the most, clear redness right over it, or erythema, and localized hyperthermia feels much hotter just in that area. Staph tends to clump up and wall itself off.
So if I can feel a definite, sore, maybe deep lump that feels a bit boggy or fluid-filled, that screams staph.
It's a strong indicator, yes, that classic abscess pattern.
And where can these abscesses actually form? What's the geography inside the breast?
It can get complicated. They can be unicentric, just one pocket, or multicentric, like a cluster of little pockets.
Okay.
The sources list 4 main zones, and the location really impacts how easy it is to treat. First, subcutaneous, just under the skin, pretty shallow.
Right.
Second, subareolar, right beneath the nipple and areola. These are often tied to those duct issues like periductal mastitis.
Makes sense.
Third, interlobular. These are deeper, running between the lobes of the breast tissue, often related to the ducts themselves. Deeper still.
And fourth, the trickiest, retromammary. This means the abscess is way back, sitting against the chest muscle, the pectoralis.
Wow, that sounds hard to reach.
It is. And draining a retromammary abscess, especially without guidance, carries more risk because you're close to the chest wall. But the typical staph pattern remains that focused collection no matter how deep it goes.
Okay, so that's the localized staph picture. How does strep usually behave in contrast?
Strep tends to spread out more. It favors a diffuse, superficial pattern, more like cellulitis.
Ah, so less of a lump, more of a widespread redness.
Exactly. Instead of that hard, localized pocket of pus, you often see redness spreading across the surface of the breast. It behaves more like a general skin infection that's involving the breast area, rather than a deep, walled-off collection.
And does that change the treatment approach?
Yes, definitely. Because it's diffuse, the strategy focuses on local care like warm compresses to help with drainage and blood flow, combined with systemic IV antibiotics right away. Usually penicillins or cephalosporins, things that cover strep well. This leads us nicely into something the source material really highlights: the massive shift in how breast abscesses are managed. You mentioned the old way sounded, well, pretty invasive.
Oh, it was. Historically, for a very long time, the standard treatment for almost any breast abscess was operative incision and drainage, IND.
Which means?
Operating room, anesthesia, often general, making a cut, draining the pus, often packing the wound. It meant significant scarring, a longer recovery. It worked, it got the pus out, but it was definitely aggressive. High morbidity.
So what's the modern thinking? What's the first-line approach now, and why is it so much better for the patient?
The modern approach flips the script. The initial strategy is now antibiotics combined with repeated aspiration of the pus.
Just draining it with a needle.
Exactly. And crucially, this aspiration should ideally be guided by ultrasound. This move away from automatic surgery is huge.
Why is this such a big deal?
The benefits are massive. It dramatically cuts down on patient morbidity, less pain, less tissue damage. It minimizes scarring, often just leaving a tiny needle mark. It usually avoids general anesthesia. And it significantly shortens recovery time, getting patients back to their lives much faster. It's a fantastic example of minimally invasive principles applied to a common problem.
Let's focus on that ultrasound guidance for a second. You said ideally guided. Why is seeing it on screen so important, especially for those deeper abscesses?
Ultrasound is absolutely key for really 3 main reasons. First, confirmation. Is this lump actually fluid-filled, an abscess, or is it solid? Sometimes you can't tell just by feel.
Okay.
Second, safety during the procedure. For those deep ones, especially retromammary, you're near the chest wall, blood vessels. Draining blind is risky. Ultrasound lets you see the needle tip in real time, guiding it safely into the pus pocket and avoiding vital structures. And third, completeness. Remember, multicentric abscesses. Ultrasound can show you if there are multiple pockets. You might drain one, but if there are others nearby, you need to get those too, or it'll just come back. Ultrasound helps map it all out.
That's really clever. So is incision and drainage totally gone? Or are there still times when surgery is the right call?
Oh, IND definitely still has its place. It's just reserved for specific situations now.
Like when?
Primarily if aspiration fails, meaning you've tried aspirating maybe 3 or 4 times, the patient's on the right antibiotics, but the collection just isn't clearing up.
Okay, persisting cases.
Right. Or, importantly, if the skin over the abscess is clearly damaged, if it's getting really thin or looks like it's dying off, necrotic, that suggests it's about to rupture anyway, and surgery is needed to control the situation.
And even then, ultrasound first.
Absolutely. Even if you know you're going to surgery, preoperative ultrasound is vital to map out exactly how far the infection spreads so the surgeon knows precisely where and how much to drain. It ensures the surgery is adequate but targeted.
Okay, before we leave bacterial infections, let's revisit that scary overlap with cancer. The sources are adamant about vigilance. If an abscess or inflamed area doesn't get better with treatment, what's the crucial next step?
This is non-negotiable. If the standard treatment antibiotics and drainage isn't working, you must strongly consider biopsying the wall of the abscess cavity.
Why biopsy the abscess wall?
Because there's a specific aggressive type of breast cancer called inflammatory breast cancer, or IBC, and it's notorious for mimicking infection.
How does it mimic it?
IBC often presents with rapid onset redness, swelling, warmth, the classic signs of cellulitis or mastitis, but often without a distinct lump you can feel. It happens because cancer cells are blocking the lymph vessels in the skin.
Wow.
So if you treat what looks like an infection for, say, 2 weeks, and it's not clearing up properly, alarm bells should ring. You have to rule out IBC. Missing it, thinking it's just a stubborn abscess, is incredibly dangerous because it delays essential cancer treatment. The biopsy is how you catch that mimic.
That's a critical safety net. Okay, let's shift gears now to section B, puerperal mastitis. This is the one linked specifically to postpartum and breastfeeding. These infections seem to come on strong. When do they usually appear?
Typically right in those first few weeks after starting breastfeeding, and we generally split them into 2 types, which are quite different in terms of cause and severity: epidemic and non-epidemic, or sporadic.
Let's tackle the scary one first. Epidemic puerperal mastitis. What makes it epidemic and more severe?
Epidemic here usually refers to outbreaks, often in hospital settings historically, caused by particularly nasty, highly virulent strains of bacteria. Most notoriously, MRSA, methicillin-resistant Staph aureus.
MRSA.
Yeah. This aggressive, often antibiotic-resistant bug can be transmitted from the hospital environment or even via the baby if the baby is colonized. Because the bacteria are so potent, these infections can cause significant illness in the mother, serious morbidity, and in the past, even mortality, though that's rare now with better treatments.
And clinically,
Yeah.
what might you see?
It's usually a very severe infection. You might even see pus, purulent fluid, actually being expressed from the nipple ducts.
Yikes. So what's the immediate action plan for something that virulent?
You have to act fast and aggressively. Key steps are: immediately stop breastfeeding on that affected side, get high-dose antibiotics started right away that cover MRSA, and often surgical drainage is needed pretty quickly because MRSA can destroy tissue rapidly and form deep abscesses.
Okay, stop feeding, strong antibiotics, probable surgery. Now compare that to the much more common type, non-epidemic or sporadic puerperal mastitis. This sounds less about a superbug and more about mechanics.
Exactly right. This type usually involves the connective tissue between the breast lobes and is typically caused by less aggressive strains of staph or strep. The trigger is often a combination of 2 things happening together:
Which are?
nipple fissuring little cracks or breaks in the nipple skin, which let bacteria in combined with milk stasis.
Milk stasis, stagnant milk. Why is that so crucial?
Because milk that isn't flowing, isn't being drained properly, basically creates a blockage and pressure buildup. This stagnant milk is like a perfect nutrient-rich soup for bacteria that have snuck in through those nipple cracks.
A breeding ground.
Precisely. The pressure causes inflammation, the bacteria multiply like crazy in the stagnant milk, and you get this infection moving backwards up the ducts into the breast tissue.
And this leads to the really key difference in management compared to the epidemic type, right? You don't necessarily stop emptying the breast.
That is the absolute defining difference. For this common, non-epidemic type, the crucial strategy is to keep emptying the breast, actively.
Pumping.
Yes, using a breast pump effectively, or careful manual expression. The logic is simple. Remove the food source, the stagnant milk. When you do that, the antibiotics work much better, the inflammation goes down faster.
So it actually helps resolve it quicker.
Dramatically. It shortens how long the symptoms last and really cuts down the chance of it coming back. So it's continued emptying plus the right antibiotics. That combination is key for a good outcome. You have to encourage the patient to keep draining that milk.
Fascinating difference. Okay, stepping away from the acute postpartum issues, what about chronic infections? If someone keeps getting abscesses, maybe not related to lactation, and the usual cultures aren't helpful.
Yeah, for those chronic recurrent abscesses, especially outside of lactation, you have to dig deeper than just looking for staph and strep. The sources emphasize doing more comprehensive cultures.
Looking for less common bugs.
Exactly. Things like anaerobic bacteria, bacteria that live without oxygen, various types of fungi, and importantly, something called acid-fast bacilli.
Acid-fast bacilli. For listeners maybe not familiar with lab terms, what are those and what condition are we thinking of?
Acid-fast bacilli, or AFB, are a type of bacteria that have a really waxy outer layer. This layer resists the standard stains used in the lab, so they need a special acid-fast staining process to be seen. In the context of a chronic breast abscess, finding AFB is often the telltale sign of a mycobacterial infection. The most well-known mycobacterium is the one causing tuberculosis, TB.
TB in the breast. Is that common?
It's rare, definitely not common, but it happens. And it typically presents exactly like this. A chronic, stubborn abscess that just won't heal with standard treatment. Finding AFB, whether it's TB or another mycobacterium, is critical because these infections need very specific, long-term antibiotic regimens, sometimes for many months, not just a week or two. If you miss the AFB, the abscess will just keep coming back.
Really important to consider those unusual suspects in chronic cases. Okay, let's move into Section C, chronic inflammatory states, specifically duct ictasia and periductal mastitis. You said these are less about outside bacteria and more about internal changes.
That's generally right. These conditions are typically associated with the involution phase of the breast, basically, as the breast tissue naturally starts to change and regress with age, usually hitting women somewhere between 35 and 55. They're intrinsic problems related to how the ducts are changing and handling secretions.
Let's define duct ictasia first. What does that mean?
Duct ictasia literally means dilation or widening of the major ducts right under the nipple, the subareolar ducts. These main tubes get stretched out, sometimes enough that you can actually feel them as a lump or cord, and it's often associated with nipple discharge, which can be thick, sticky, sometimes greenish or blackish.
So the pipes are getting wider. Now, the interesting part here, according to the source, is the why. There seem to be two competing ideas about what causes this.
Yes, this is a classic chicken or egg scenario in pathology, and it highlights how complex these things can be.
Yeah.
There are two main theories, and they might even both play a role sometimes.
Okay, lay them out for us.
The traditional view is Hogginson's primary ictasia theory. This suggests the first thing that happens is the duct gets wider, it dilates.
Okay, dilation first.
Right. This widening leads to secretions pooling inside, stagnating, milk components, cellular debris just sitting there. This stagnant stuff chemically irritates the lining of the duct, causing it to break down, ulcerate. Then these irritating substances, especially fatty acids from broken down secretions, leak out into the tissue around the duct. The body reacts with intense inflammation in that periductal tissue, leading to scarring or fibrosis. And eventually, that scar tissue contracts and pulls the nipple inwards. Classic nipple retraction.
So dilation, stagnation, leakage, inflammation, scarring, retraction, all cascade started by the widening.
Exactly. Dilation leads to inflammation. That's Hogginson's model.
But there's an alternative theory.
Yes, sometimes called the primary mastitis theory. This flips the sequence. It proposes that the inflammation around the duct, the periductal mastitis, happens first.
Inflammation first, what would cause that?
Maybe a chronic low-grade infection or irritation perhaps related to smoking, which is strongly linked to periductal mastitis. This initial inflammation then weakens the wall of the duct from the outside. The weakened duct then gives way under normal internal pressure and dilates secondarily. So, ictasia is the result of the inflammation, not the cause.
So, inflammation weakens the pipe, then it stretches. Why did this alternative idea even come up if Higginson seemed logical?
Well, clinically, the end results often look very similar, but the primary mastitis theory suggests that maybe if you could treat the inflammation early, you could prevent the duct from dilating in the first place. It reflects ongoing research and debate about whether the duct wall itself fails first, or if external factors damage the supporting tissue, causing the duct wall to fail.
Interesting. So the trigger is debated, but the downstream effects are similar.
Pretty much. Both theories agree on the eventual outcome. Inflammation, fibrosis, retraction, they just disagree on what lit the fuse.
And regardless of the starting point, this chronic inflammation can lead to a range of clinical problems for the patient.
Absolutely. It's a chronic process. Patients might experience, definitely. Managing a mammary duct fistula usually requires surgery. The standard approach is to excise the entire affected duct system, including the fistula tract, to break that chronic cycle of blockage and infection. It can be quite complex.
Okay, moving to our last category, Section D. Other specific inflammatory conditions. We have two Quite different things here. Hidradenitis suppurativa and Mondor's disease. Let's start with hidradenitis. You usually associate that with armpits or the groin. How does it affect the breast area?
Right. Hidradenitis suppurativa, or HS, is a chronic inflammatory condition primarily affecting apocrine sweat glands. In the breast area, it can arise from the accessory areolar glands, those little bumps around the nipple called Montgomery's glands,
Yeah.
or it can involve the regular apocrine or sebaceous glands in the nearby axilla, the armpit, and sort of spread towards the breast. Fundamentally, it's about recurrent blockage, inflammation, and infection of these glands.
Are certain people more prone to getting it near the breast?
Yes, the sources mention a link. Women who suffer from chronic, severe acne seem to be at higher risk for developing HS in general, including in this area. It often seems to be part of a broader pattern of skin inflammation.
What does it look like clinically?
It typically involves painful nodules under the skin that can rupture, drain pus, heal with scarring, and then unfortunately recur. Over time, this can lead to tunnels or sinus tracts forming under the skin. It's often painful and can be quite debilitating.
Now, the location near the nipple sounds like it causes diagnostic headaches. Why is it so easily confused with more serious things?
This is one of the biggest mimics we've discussed. When HS occurs right around the nipple areola complex, the chronic infection, the drainage, the hard scar tissue it creates, the redness, it can look remarkably similar to several very serious conditions.
Like what?
Like the chronic inflammatory states we just discussed, sure, but more worryingly, it can look almost identical to Paget's disease of the nipple, which is a form of cancer involving the skin of the nipple, or even like an invasive breast cancer that's infiltrating the skin. The chronic drainage and skin changes can really obscure the picture.
So biopsy is often needed.
Very often, yes, because telling them apart clinically can be so difficult, especially if it's just on one side or looks unusual. You really need a high index of suspicion. A biopsy is frequently necessary just to be absolutely certain you're not missing a malignancy before you treat it as just hidradenitis.
And how do you treat hidradenitis once confirmed?
Initial management often involves antibiotics for flare-ups and incision and drainage if there are distinct fluid collections. But because HS is chronic and tends to form those deep tunnels, just draining it isn't usually curative.
So more extensive treatment.
Often, yes. For persistent or widespread disease, the definitive treatment is usually wide surgical excision of all the involved skin and underlying glandular tissue, getting rid of all those chronically inflamed glands and tracts.
That sounds like it could leave a large defect.
It can. If a large area is removed, closing the wound might require more complex reconstructive techniques, like using nearby skin flaps, advancement flaps, or even needing split-thickness skin grafts. It can be a significant surgical undertaking.
Okay, quite serious. Let's end this section with something hopefully less serious. Mondor's disease. You said this one is usually benign.
Yes. This is the good news diagnosis, relatively speaking. Mondor's disease sounds alarming, but is generally self-limiting.
So what is it exactly?
It's a thrombophlebitis, meaning inflammation and clotting of a superficial vein on the chest wall or breast. Henri Mondor described it back in 1939 as string phlebitis, and that's actually a great description. It feels like a cord or string under the skin.
Which veins usually get involved?
Most commonly, it's the lateral thoracic vein, which runs down the side of the chest, or the thoracoepigastric vein, which connects veins in the upper abdomen and chest. Sometimes the superficial epigastric vein lower down. Basically, one of these surface veins gets inflamed and clotted.
How does someone realize they have it? What are the symptoms?
It usually presents quite suddenly with localized pain in the area of the vein. Sometimes people recall a minor injury, muscle strain, or even recent surgery, but often there's no clear trigger. On examination, the key finding is that tender, firm, cord-like structure you can feel and sometimes even see running along the path of the vein.
Does it happen on both sides?
Rarely. It's almost always unilateral, just one side. And importantly, while it's sore locally, patients don't usually have signs of deep vein thrombosis, DVT, or clotting problems elsewhere in the body.
And the most crucial point for anyone experiencing this?
Reassurance. The source material really stresses this. Mondor's is benign and self-limited. It is not cancer. That palpable cord can feel very much like a tumor, so letting the patient know what it really is incredibly important.
How is it managed then?
Simple, conservative management. Anti-inflammatory medications like ibuprofen are helpful for the pain and inflammation. Warm compresses applied to the area can also feel good and may help resolution.
And it just goes away on its own?
Pretty much always, yes. It typically resolves completely within about 4 to 6 weeks. The pain settles and the cord gradually disappears.
When would you ever biopsy it?
Only really if the diagnosis isn't clear-cut, if it doesn't quite feel like that classic cord, or if there's something else concerning nearby, like a separate lump that needs investigation. Otherwise, biopsy isn't needed, just watchful waiting and symptom management.
Okay, that's a relief to know about. Right, we've covered a lot of ground, different infections, chronic issues, that vascular oddity. Let's try to bring it together in section 3, modern management trends. What's the big picture for a patient today facing these issues?
I think the dominant theme is definitely the shift towards minimally invasive approaches, really driven by better imaging. And the absolute standout example, as we talked about, is how we now manage non-lactational breast abscesses.
Remind us of that core change again.
Moving away from routine, upfront surgical incision and drainage for almost everyone towards a first-line approach of antibiotics combined with ultrasound-guided aspiration.
And the impact of that shift. Why is needle aspiration so much better than surgery when possible?
It comes down to quality of life and recovery. Using a needle under ultrasound guidance when appropriate means no general anesthesia typically, much smaller wound, minimal scarring, less pain, and a way faster return to normal activities, work, life.
Right.
We're effectively treating the infection and getting the pus out with a controlled puncture, saving the bigger operation, the IND, for cases that truly need it, the ones that fail aspiration or have significant tissue damage. It respects the patient's body and time much more.
And ultrasound is the key enabler for this. It's not just for diagnosis anymore.
Absolutely not. It's become integral to treatment. First, diagnosis. Is it fluid or solid? That's often impossible to tell just by feel. Second, guidance during aspiration. It ensures you hit the pocket accurately and, crucially, safely, avoiding the chest wall or blood vessels, especially with deep abscesses.
We discussed that safety aspect.
Yeah, draining blind can be risky. Third, assessing completeness. Did we get all the pockets if it's multicentric? And fourth, even if surgery is needed, ultrasound maps the extent beforehand, allowing for a more precise, targeted operation, minimizing how much tissue needs to be disturbed.
So the modern mantra is precision. Image well, diagnose accurately, guide treatment carefully, and escalate invasiveness only when necessary.
That sums it up perfectly. Precision is the goal.
But woven through all this is that constant challenge you mentioned, telling these inflammatory things apart from cancer.
Exactly. That's the real clinical tightrope walk. The complexity isn't just treating the infection or inflammation, it's being certain you're not missing something more sinister hiding underneath.
Because the symptoms overlap so much.
Yes. The body's reaction to severe inflammation creating lumps, redness, skin thickening, retraction, like we saw with hidradenitis or even chronic abscesses, can look frighteningly similar to cancer, both clinically and sometimes even on initial scans.
But that's where biopsy comes back in.
It has to. That need for certainty is why biopsy becomes mandatory. If symptoms are weird, if treatment isn't working as expected, or if the whole picture just doesn't quite fit a clear benign diagnosis. The modern approach demands diagnostic rigor be aggressive in confirming the diagnosis while often being conservative in the initial treatment approach.
Right, okay. So let's wrap this up. What does this all mean? We've journeyed through a whole landscape of breast inflammation. It's clearly not just one thing.
Not at all. It's incredibly diverse.
Wow.
From those acute bacterial hits like staph and strep,
Right, causing abscesses or cellulitis.
to the chronic issues stemming from the ducts themselves like duct ectasia and periductal mastitis.
The internal plumbing problem.
And even that unique vascular issue, Mondor's disease, which is inflammation in a vein. And then the tricky mimics like hidradenitis.
So the mechanisms are varied. Infection, inflammation due to internal changes or stagnation, vascular issues.
Precisely. And recognizing which mechanism is likely at play is key to planning the right management.
And the clinical imperative moving forward, what's the main message?
It really feels like two sides of the same coin. First, make sure the diagnosis is right and use modern, often less invasive treatments appropriately. Prioritize things like aspiration for abscesses when safe, avoiding unnecessary major surgery. That respects the patient.
And the other side of the coin.
Never drop your guard against malignancy. Always remember inflammatory breast cancer and other mimics. Any inflammation that doesn't resolve as expected needs a thorough workup to rule out cancer. Delaying that diagnosis is the worst outcome.
Which leads us to our final thought, something for you, the listener, to ponder. We talked quite a bit about how these non-cancerous but severe inflammatory conditions, chronic HS, stubborn abscesses, can look and feel so much like invasive cancer that you absolutely need a biopsy to tell them apart.
Yeah, the clinical overlap is striking. The body's response to intense localized stress, The redness, the swelling, the hardness from scarring it uses a visual language that's incredibly similar to how cancer can present when it infiltrates tissues.
So, if that basic inflammatory response can mimic malignancy so closely that we need to physically sample the tissue to be sure, what does that tell us about how fundamental these responses are? And looking forward, how much better does our imaging need to get? Will we move beyond just seeing structures to maybe visualizing molecular processes, inflammation versus malignancy at a cellular level? Can we reach a point where we can reliably distinguish the process benign inflammation from the disease-invasive cancer without always needing that biopsy, without needing the knife?
That's the million-dollar question, isn't it? It really pushes the boundaries of diagnostic imaging and our understanding of tissue response. A fascinating challenge for the future.
Indeed. Something to think about. Thank you for joining us on the Deep Dive.